Yeah, so I'll be recording this meeting and then I'll be sharing it with you through my YouTube channel. So all of you can have an access to it. So it will be on my main YouTube channel. Okay. So Dr. Bilal will be going first, and Dr. Alifia would be going ahead. So all of you, I will give 3 minutes to everyone. Okay. And then we can start. Okay. So Dr. Bilal, you want to do the knee examination. So let's start with that first. So you have a patient and he had a fall while playing soccer and injured his knee. So you have to examine his knee in the next 3 minutes. Okay.
Okay, no history, nothing, right?
No, I will just give the scenario. It's just physical exam, quick review. So 3 minutes
Okay.
for everyone. Yeah. So
Okay.
I'll
Can
put
I
on the
just get
time.
can I get the 30 seconds to just like think about?
Yes, you can think about it.
Uh, mm, Okay, so I'll start.
Okay.
So I'll first introduce to the patient, and then I'll just go through the like sanitizing the hand. So I would look and feel your legs, and I'll be exposing your lower limbs. That would be fine with you?
Yes, doctor, please proceed.
Okay. So I'll expose the patient first, both legs and till his upper thighs, and then I'll start with the inspection. I'll first ask for the vital signs. Vital signs are stable, I'm thinking, and then I'll go for the inspection. So first
Mhm.
I'll do the seeds, swelling, erythema, atrophy, any deformity, any scars. Then I'll see is there any other things which is visualized. Is there any
Mhm.
swelling positive or any injury, any scar?
So you can see mild swelling on the left knee, and there is no discharge. You can proceed.
Okay. Then I'll start with the palpation, and I'll first take the temperature of his lower limbs, like by touching my back of the hand, but like simultaneously on the both legs from the ankle, calves, and thighs. Then I'll start with the extended knee, like while he's like lying down. I will try to palpate his tenderness over the patella.
Bilal,
Uh,
sorry, I will stop you here for a while. I
yeah,
want you to
yeah,
do it in the way you will do in the examination. So, for example, if I'm the patient and you are giving
yeah.
me
Mhm.
the instructions, so you can
Okay,
tell me that, okay, so for
okay.
example, my name is Mark. So you can say that,
Hmm.
Mark, I'm not going to examine your knee. So I
Hmm.
want you to do it in that way, okay?
Okay. So Mark, now I've done with the inspection. Now I'll be feeling your knee. Okay. If there's any pain, you can tell me, and I'll stop at that point. Okay.
Doctor.
So I'll first I'm touching your patella for any tenderness. Is there any tenderness over here?
Yes, doctor, there's some pain over here.
Okay. I'll be slightly moving it around. Let me know if there is a discomfort or not. Okay. So I'll do some lateral movements of the patella. Is it painful or not?
So it's not painful, proceed.
Okay, and then I'll check. Then I'm touching his upper part of the knee, and
Mm-hmm.
to check the ligament over there, and quadriceps tendon, quadriceps muscle on the behind of the knee,
Mm-hmm.
and below the knee joint, like the below the patella, and
Mm-hmm.
I'll be checking his tuberosity,
Mm-hmm.
and I'll also palpate the popliteal fossa.
Mm-hmm.
And is there any discomfort over here?
Yes, doctor, there is mild discomfort along the tibial tubercle.
Okay. I'll be doing the same thing on the opposite leg too, on the left and the right. Is there any discomfort on the right side?
No, the right knee is normal. Proceed.
Okay, then I'll ask the patient to flex his knee, like kindly raise your legs and I'll flex your knee on the couch. So your foot is on the couch and your knee is flexed. Okay.
Okay.
And then I'll be checking for uh, the tuberosities again and joint lines, and the ligaments on the surrounding, and
Mhm.
femoral condyles, and I'll be also doing some checking for the crepitus over the patella, and
Mhm.
I'll also check the popliteal fossa and the muscles below the popliteal, like calf muscles and the quadriceps muscles. Is there any tenderness over here?
So there is no tenderness in the popliteal fossa. I want you to do anterior posterior draw test. So
Okay.
instruct the patient and do that.
Mm, so for the special test, if I'm sure, I'm not 100% sure, but for the anterior draw test, we put the foot in this flex position, and then I'll keep the hands behind your upper calf from the behind and pull the leg forward, like in that sort of like give a pressure to
Yeah.
check the anterior draw test. And if there's positive sign, it could be some anterior cruciate ligament tear. So do you have any pain over there?
There is mild pain on anterior draw test.
Okay, and I'll also go to the posterior one too. Is there any discomfort, like pushing the same thing on the opposite side behind?
No, there is no discomfort on posterior draw test.
Okay,
Okay, I'll
I'm not
stop
sure.
you here now.
Yeah. Yep,
Yeah, your time is also up.
yep,
So,
yep, yep, yep.
yeah. So, anyone else who would like to do the knee examination? One. All
I
right.
can try. I
Yes,
can.
please. Yeah. Yes, go ahead, Sana.
Sorry. Should I do the whole knee test, or you want me to do something particular?
So I want you to do the complete knee examination.
Okay, just give me 1 second.
Yeah, and you have 3 minutes for that. Okay, as much as you can do, and do it in the way you will be telling the patient in the exam.
Okay, just 1 second.
Okay.
Okay, should I start?
Yes, please.
Okay, thank you so much for the history. I'll need the set of vitals of the patient.
The patient is vitally stable. Please proceed.
Thank you. So now I'll be exposing you till your thighs. Is that okay with you?
Okay, that's fine. Please proceed.
So my examination will include touching and feeling. So now I'm going to start by looking at the symmetry of both the knees, looking for any redness, any swelling, any deformities.
There is a mild swelling on the left knee. Proceed.
Okay, now I'm going to thank you. So now I'm going to touch for the temperature, check the temperature in both the knees, whether there's raised or not.
Temperature is normal. Proceed.
Now I'm going to start by palpating for the knee joints and the patella and back of the knee and the cubital fossa.
There is mild tenderness along the joint lines. Proceed.
Okay, now I'm going to look for crepitations or effusion.
Okay, so there is mild effusion. Proceed.
Now I'm going to do the movement of the knee, do the flexion and extension. Any pain
Range of
elicit?
so how will you ask the patient to do extension and flexion?
So I'm going to ask the patient to bend his knee and put his knee forward, put his leg forward.
Okay, so range of motion is reduced in the left knee.
Okay, now I'm going to
Proceed.
do the motor exam. I'm going to ask the patient to press against the resistance. I'm going to place my hand on the thigh and ask the patient to resist. Now I'm going to ask the patient to pretend to kick, and I'm going to check for the resistance there as well, and ask the patient to press like he's pressing on the gas pedal and look for the resistance there as well. So I'm checking L4, L5, and S1.
So L4, L5, S1 is intact. Proceed.
Okay, now I'm going to do the special test. So I'm going to do the ACL test. I'm going to sit at the bedside of the patient. I'm going to sit on his foot to stabilize the knee joint and in the bend position at 90 degrees and ask the patient and move the tibia forward and see if there is any pain elicited or if the movements is very frequent.
So there is pain on anterior drawer test.
Okay, so now I'm going to do the posterior draw test and see if the same way, but I'm going to push it down and see if the patient has any laxity of the muscles.
The posterior draw test is negative. Proceed.
Okay, now I'm going to do the sensory test. I'm going to see L4, L5, and S1. So I'm going to check, I'm going to see I'm going to ask the patient, I'm going to put the cotton on your hand. If you feel it, then let me know if once your eyes are closed. So I'm going to ask the patient to close his eyes, put the cotton swab on the knee, checking for L5. On the lateral side, on the lateral side to check for L4, and on the medial side to check for L4, lateral side to check for L5, and the pinky toe to check for S1. Sorry,
Okay,
doctor, I
so
can hear you.
yeah, so sensations are intact. Now proceed. One more thing
Now
I
I'm
want
going,
you to do before I stop you.
okay, so I want to do the reflexes as well.
Reflexes are intact. Proceed.
Do you want me to do the McMurray test?
No, you have
Leishman
already done the
test.
specialist.
Lackman
Left.
test?
No, come out of the knee. Come out of the knee zone.
Oh, and sorry, I'm going to check the peripheral pulses as well to check for dorsalis pedis and posterior tibialis.
They are palpable. What else?
And I'm going to check the knee, the posterior side of the knee to check for any swellings.
Oh, gait.
And then check for the gait as well. Ask the patient to walk 3 steps ahead while I'm supporting him and walk back as well. And then ask him to walk on his heels, checking for S1, and walk on his tippy toes to check for L5.
Okay, you have last 10 seconds. One more thing. Come on.
Check the
Um,
You
pelvic
have to
and
complete your
ankle.
examination. Sorry?
Check the pelvic and ankle.
Check what? Sorry?
Check pelvic and ankle joint.
Yes. Thank you, Bobak. So we have to check the joint above and joint below. Never forget that in the MSK examination that I will complete my examination by checking the joint above and joint below. So, Bobak, coming to you after this, how will you do the hip examination? Can you do that?
Me talk about.
Yes.
Okay,
Yes.
okay, thank you, John. Now I want to do a physical examination on your pelvic area. I want to expose your private area. Is that okay with you?
Yes, doctor,
I,
that's
I
okay.
will
Proceed.
cover by a sheet the area and just want to check your pelvic. Is that okay with you?
Yes, doctor, that's fine.
Okay, I'm inspecting the area looking for any swelling, erythema, atrophy, deformity, or skin changes in the
So there is
pelvic.
nothing. Proceed. It's normal. Proceed.
Okay, I want to check the palpate the area looking for any tenderness on the pelvis, on any temperature change or any crepitation.
So it's negative. Proceed.
Okay, I want to check the range of motion of the pelvic. Can you bend forward and touch your toes?
You mean yes, the patient can bend forward and touching the toes. Now, what are you examining for?
I'm looking for the flexion of the hip. And for the extension, can you arc your back as far as possible?
Mhm. So extension and flexion is intact. So when
And
you're
can you
doing
slide your hands to your legs bilaterally?
okay,
Okay,
proceed.
and now I want to check your movement. Can you stand on your foot and walk for me?
If the patient has Trendelberg gait, what does that mean? Limping on one side.
Uh, it could be a side joint involvement,
Mhm.
or so I will go for checking the Faber test, ask, and I will check the Schubert test as well. I can check Schubert in the standing position, mark SI joint 10 centimeter above and 5 centimeter below, and ask for the patient to bend forward. And if the distance is less than 15 centimeter, it means that the patient have some kind of restricted or a stiffness in the sacroiliac joint or in the pelvis.
Okay. So when the patient is bent forward and you are looking at the patient from the back, also look for scoliosis at the same time. Okay.
Oh,
So
scoliosis. Okay.
yeah, on inspection. So when the patient is touching their feet, bending forward, touching their feet, so go at the back of the patient and look for scoliosis as well. Okay, any scoliosis is there or not. So that will and what else will you do for the knee examination once the patient is lying down? What will
The
be
patient is lying down. I will check SLR,
and femoral
straight
test?
leg
How will
test.
you do that?
I will raise the leg, and if the patient has pain in between 30 to 70 degrees, it means that it's lumbar disc herniation. But it's if less than 30 degree has pain, it means that hip joint is involved.
Okay. Okay, good. Okay. So moving forward, if we can have Dr. Alifia, can you do the shoulder examination?
Yes, doctor, I can. Okay,
You
can
can
I
do that?
start?
Yes,
Yes.
please.
Okay, I'll first of all sanitize my hands and ask the consent of the patient. Is it okay if I can do it? Ask the patient to remove the drape, expose both the shoulders bilaterally, starting with the inspection, looking for any visible veins, scars, pulsation, any deformity, any discoloration, and any abnormal deformity of the joint. Okay. Um,
Okay, it's normal. Proceed.
Then moving on to palpation, I'll palpate to look for the temperature of the joint, ask for any pain anywhere, and start to palpate the joint line, looking for tenderness and any crepitus. Then
Okay.
moving on to range of motion, I'll ask the
Mhm.
patient to move the hands forward in front of them to look for flexion, move it backwards to check for extension, touch the opposite shoulder and
Mhm.
check for um, internal rotation, and then back of the shoulder external rotation. Move the hand all the way about to touch the head for abduction and reverse back for adduction. um,
Mhm.
then also check for power of the joint, tone and power. So tone is by passive movement of the joint, and power is by asking the patient to the same movements which we did but with resistance. Okay. Then checking for sensation bilaterally, just picking a tissue, checking the shoulder joint area, below the shoulder joint area, about the near the clavicular area, and just the hand. So like T1, C5, C6, C7, C8, and T1 dermatomes. Then moving on, I would like to do some special tests of the shoulder. So an empty can test, reverse the hand downwards towards the thumb pointing downwards and to see if there is any pain. Um, then do impingement test, hold the shoulder joint and ask the patient to move the hand up above and bend the hand down, like pointing downwards. So looking for any impingement. Um, then and check for biceps and triceps reflex.
Mhm.
Yeah, and that's about it. Thank you.
Okay, thank you.
And also check the joint below and completed by elbow joint examination and cervical spine examination.
Okay, okay, good. So what I'll do is I'll quickly share the just the shoulder examination that we did in the class as well. If I can share that with you so that you know how to give instructions for all those who are in the session right now. Let me go to that slide. Mm, okay, sorry, I'll stop sharing this one. Just 1 second. Okay, so yes, Sophia, you have a question?
Yes, Dr. Sana. I wanted to ask, when we're doing these MSK examinations, do we have enough time to do the examination of the other knee? Like, suppose the right knee is affected, or will we just say, like, ideally, I would like to compare my findings with the left knee simultaneously?
So you can just give that statement. You don't have the time to just
Okay.
with everything, just add bilaterally that I'm inspecting the knees bilaterally.
Mm-hmm.
I'm now going for palpation bilaterally. So those of you these are some of the slides that I had in my crash course, just to go through the knee, a quick shoulder examination, how to give instructions to the patient. So for like Alifia also did a good job there. So limited range of motion for we did it for frozen shoulder, but you can do it for other pathologies as well. So can you reach behind your head and touch opposite shoulder blade? This is for external rotation. And now can you reach behind your back and try to reach your lower shoulder blade? So for internal rotation. So then for the impingement test, then you can see that I'm going to raise your arm straight up in front of you while I stabilize you. So you hold the shoulder of the patient and raise their hand, and let me know if you can just leave something in the chat. Sorry. Um, as well. Yes, Mehak, I will give you as well. So the sensory distribution in MSK, yes, if you have time, yes, of course you will do that. That will complete your examination, yes. So yeah. Yes, India, I'll give everyone, I'll try to give everyone a case. We have 1 hour, so we'll try to be as quick as we can. Okay. So, sorry. Okay. So this is how you'll give the instructions to patient for impingement test. Then moving forward, this is how you can give the patient for Hawkins-Kennedy test. That I'm going to bend your elbow and lift your arm to the side, then rotate it inward. So you tell me if that causes any pain. So, or you can just do that in front of the patient and tell them how you, and then drop arm test. And these are some of the interpretations that you have with the drop arm test. And then identify the range where pain occurs. So for the painful arc, and then passive and active range of motion. So this is how you go ahead with the shoulder examination. So next, okay, so next, Mehak, you can take the next one. Can you do the carpal tunnel examination?
Okay, sure. So, shall I start?
Yes, please start.
Okay, thank you for the history, John. Now I would proceed with the examination of your hands and wrists. Will that be okay with you?
Yes, doctor, that's fine.
Okay, thank you. Sanitizing my hand and asking the vitals from the examiner. So, can I have a
Patient is
sit with?
vitally stable. Proceed.
Okay, thank you so much. Thank you. My patient is hemodynamically stable. So please, can you bring your? I will be putting a drape around the table, and can you put your hands here? I just want to. I'm on inspecting. I'm looking for any swellings, any deformities, any scars, or any erythema. And I'm also noticing if there is any tremors. Can you please now change the position of the hands? I'm looking for any the tone of hypothenar and thenar muscles and looking for any palmar contractures. So now I'm also checking the temperature on both the hands. So the temperature looks, can I have the temperature?
Yeah, it is normal. You can proceed.
Okay, thank you. The temperature is normal. Now I'm looking for the radial pulse and checking for radial pulse and looking if that's regular or not. And radial pulse is regular.
Pulses are intact. Proceed.
Okay, thank you. Now I'm palpating the joints. I'll be touching the distal interphalangeals and carpal joints. So I'll be palpating on the hands, especially on the affected hand, and I'll be also touching the wrist, and I'll be also palpating the anatomical snuff box to see if there is any pain. So do you feel any pain, John, anywhere? And during the examination, if you feel any pain, just let me know. I'll be stopping there. So
Mhm.
I'm palpating all the hand and the wrist. Okay, thank you, John. Is there any pain there?
So there is a pain along the thumb and index finger and middle finger.
Okay, all right. So John, now I'll be doing some movements of the hands. So you have to just now bring your thumb and you have to touch the thumb with all the four fingers. Are you able to do that?
Yes, doctor, I have some pain and numbness, but I can do that.
Okay, all right. I'll be telling the patient to point the thumb towards the ceiling so that I can see, and rotate the thumb in the all directions. So I'm checking all the movements of the thumb as well. And now can you bring your both hands together like and fold it. I'm checking for wrist extension, sorry. And then I'll be pulling the hand in the another direction. I'll be showing the patient in an extension in a flexion position as well. So checking for the wrist flexion, and to tell the patient, if you feel pain and discomfort, just let me know. Now I'll be taking a cotton and telling the patient, this is a piece of cotton. I'll be touching it on the other arm and telling, this is how it feels. So can you please close your eyes? I'm gonna check the sensations. So I'm putting it on the little finger and checking for I'm checking for C8, and the middle finger I'm checking for C7, and on the thumb I'm checking for C6. So if the patient tells us, I'm checking for the sensations, and sensations are intact.
Okay, yes. The sensations are
Okay.
lost on the thumb, on the medial side of thumb and index and middle finger.
Okay. So there's a loss of sensation on that side. Now I'm gonna tell the patient that this is a coin. Just bring it in your hand and bring it to the other hand. Just checking overall functioning of the hand. So in the next, I'll be telling the patient. I'll be putting my finger on the wrist and telling the patient, if you feel any sensation. So I'm checking the Tinel's test to note if there is any tingling sensation noted. That is to rule in the carpal tunnel syndrome. Also,
Okay, so Meg, I'll stop you here, and if Afida, you can take from here and perform the special test for carpal tunnel.
Okay, so I'm doing a special test. So I want you to follow what I'm doing. So I'm doing the Tenel test to see the involvement of median nerve. Can you please copy what I'm doing? I'm looking for any numbness or tingling in the three fingers.
Okay, so adrenal stress is positive. It elicits numbness and tingling in the three fingers. But how you will do it? What will you tell the patient?
So I'll be tapping on your wrist, and let me know if you feel any numbness or tingling. Right, and then I'm doing the next test, Fennel's test. So can you please, copy what I'm doing, and, bring both of your hands together and let me know if you feel any numbness or tingling.
Yes, there is numbness and tingling. Now, I also want you to do a Finkelstein test to rule out de Quervain's
Okay.
tenosynovitis. How will you
And
do that?
okay, and now I'm doing another test, that is Finkelstein test, to see if it is recurrent sinusitis, tenosynovitis. So I want you to bend your wrist down. I'll be helping you, and let me know if you feel any pain at the base of your thumb. Looking for any pain or tenderness.
Okay. And what test will you do for cervical radiculopathy to rule out C6 involvement, C6, C7 involvement? One more test.
One more test.
Sperling's test. Can you do that?
I forgot Sperling. I think.
Okay.
No.
Okay, no worries. Can someone do the Sperling's test? Someone would like to do the Sperling's test?
You try to bend the neck of the cervical spine, and you put a pressure on the head, and that would create electrical sensation or severe amount of pain.
Yeah. So that is how you do the Sperling test. Okay. So thank you, Afida and Aditya. So moving forward, Dr. Hindia, can you can you tell us the examination for BPPV, Dix Halpike test, and other investigations?
The examination we do is the Dix Helpike's maneuver.
Yes, can you do that
We
for
put
BPPV?
Oh, okay. First, I'll sanitize my hand. Can you please sit on the bed for me? And I'll make the patient sit on the bed, and I'll make him sleep on him. I'll make him become supine, and then quickly laterally rotate his head to make sure if there's any nystagmus or not. If there's any nystagmus, then that's a positive sign for BPPV. Mhm.
Okay. What other
That's,
tests
I
you will
think,
do for nystagmus? A case of
cranial nerve examination. Probably check for cranial nerve 2 or 3. Check for any nystagmus. I'm not sure, honestly.
okay. So how will you examine cranial of 2, 3, 4, 6?
Okay. Cranial nerve 2, I'll check for the visual field. Tell him to cover one eye, cover my one eye as well. Make sure he can see my fingers. To let me know when he sees my fingers. And then to actually check for visual acuity, use the flannel chart to make him read the letters, the letters to read it, and then also to check his color vision. And then also, ideally, I would also perform a fundoscopy to check for papilledema, and also cranial nerve 3, 4, 6 to check for the pupillary reflex bilaterally if it's active to light, and then also to make him look forward, not move his head, and then check for the extraocular muscles. Do the H sign, follow my fingers, and make sure to see the H follow, and then also do the convergence test. Follow my fingers, and then see if there's any deviation there.
Okay. Okay, thank you. Anyone else who would
Thank you.
like to volunteer for the next examination? Any volunteers?
Can I ask one question here?
Yes.
BPV, so we do Dix-Hallpike test and we see whether it's a right or left lesion. And then do we need to do anything else like in that case when we are thinking BPV? Or we don't need to do hint, I know, because that is central. We are looking for.
Yeah, so BPPV, we do this first the cranial nerve examination and then the Dix Hallpike. These are the two tests.
So cranial
That-
nerve,
that-
all of them or 2 to 7?
No, just 2, 3, 4, 6. That's enough.
Okay.
Yeah. Okay. So if nobody wants to volunteer, then Dr. Alifia, yes, you can go next. So Dr. Alifia, I want
Okay.
you to do a diabetic foot examination.
Sorry, can you repeat that?
Yeah, diabetic foot examination of a diabetic patient is here
Okay.
is there in your clinic, and you have to do the foot examination for that patient.
Okay. I'll start off with sanitizing my hand. Can I start?
Yes, please.
I'll start with sanitizing my hands, and I'm going to be examining your foot. Is that okay with you?
Yes, doctor, that's fine.
All right. So now I will remove the drape and I will expose the patient up to the knee joint, or above the knee joint to examine the leg. Starting off with inspection, I would like to look for any discoloration, any redness, any swelling, any ulcers, any scars, any visible veins or pulsations, or any masses present. Okay. Then next with palpation, I would like to check the temperature of the joint, both bilaterally, looking for it, whether it's warm, and ask for any pain. Do you have any pain or any discomfort anywhere? Please do let me know if there's anything uncomfortable. Then after that, I would like to check for the pulses, dorsalis pedis pulse and tibial pulse as well. And then after that, I would like to check for the range of motion. So can you please flex your legs towards towards your leg, and extend it on the opposite side. Put your leg towards inside, towards your hip, internal rotation and external rotation, both. Then inversion and eversion. I would also like to check for both all these joints with resistance as well. Now I would like to check for the sensation. So taking a cotton swab or a tissue, whatever is available, ask the patient to close the eyes, and now I'm going to touch it. Please let me know if you feel any sensation. And check below the knee for L5, L3, L4, L5, and S1. Then moving on, with the patient's eyes closed, I would ask them whether their ankle is pointing up, the toes pointing upwards or pointing downwards, proprioception.
Okay.
All right. And then I would like to do the reflex. the ankle reflex, Babinski reflex, and yes, that's about
Okay.
it. And if there is
What,
a,
yes, please.
sorry,
What
if
will
there
you
is
do
any
for vibration?
for vibration, yes, tuning fork test to check on the bony prominence on the malleolus, check for any vibratory sensation.
Okay. Okay, good.
Okay, and if there is any ulcer, then describe the ulcer and the
Yeah.
base.
Yes. Ulcer, the depth of the ulcer, any discharge is there, and the surrounding skin. Okay.
Yeah.
Anyone else who would like to volunteer?
Sorry, Dr. Sana. Was it
Yes.
for diabetic foot? Because the voice was disconnected for me.
Yes, yes. Yeah, it was diabetic foot. Yeah, diabetic foot.
And I have a question. I mean, I want to ask that in the diabetic foot, we first check monofilament and then vibration, and then we will, because the pressure sense goes first, and then vibration, and then proprioception, and proprioception also we will do.
Yes, yes, you will do all four. And it
Four.
depends. You can, yeah, but you can go with the light touch sensation first if you want to. But if you want to go with monofilament, that's also your choice. So all the sensory exam you can go in any order. You can check
Okay.
proprioception first and vibration first, and then light touch and monofilament, or you can go with monofilament first, and the rest of the test can be follow up.
And do
But,
they keep the monofilament there?
I don't think so.
Or no? Okay, just verbalizing it. And also the for the vibration tuning fork is there? Did you?
A tuning fork can be there, yeah. So if tuning fork is there, so you will take the tuning fork and touch it on the sternum of the patient. Tell the patient this is tuning fork, how it feels, and
Yeah.
now I'll be touching it. So check along with the bone of the big toe or
Big
the
toe.
ankle.
Yeah. Okay.
Yeah, this is how you do that. And for proprioception, you tell the patient then that I'll now be moving your this big toe up and down. This is how I'm moving it up. Now I'm moving it down. Now can you please close your eyes? And now can you tell me, is it up or down? Is it up or down? And then
Okay.
right there and then do the sensations. Okay. Anyone else who would like to volunteer for the next one?
Nobody's coming. I can.
So you can do the next one. So you can do peripheral arterial disease examination.
Okay.
So the patient
So,
is presenting to you with leg pain after walking, and you are suspecting peripheral arterial disease.
Or you are Mr. John, for example.
Yes,
So,
let's
Mr.
do
John.
everything on John today.
So sanitizing my hands. So Mr. John, now I'll be doing examination of your leg. So I want you to expose it. I will be draping you well. Is that okay?
Yes, doctor.
And
That's
can I
fine.
get the set of vitals, please?
So the patient is vitally stable. Proceed.
Okay. So do you have pain anywhere?
No, just in my legs after walking, but right now I'm fine.
Okay. So I'm inspecting for any swelling, discoloration, redness, ulcers, any color changes, pallor, cyanosis, and I'll be also checking the under the leg and also in between the web of the fingers for when I'm doing palpation. Now I'm doing palpation, so I'll be checking your leg. I'm first checking for any temperature difference. So I'm checking both legs. If it is
So
cold,
temperature is, yeah, so temperature is bilaterally cold. Legs are cold. Proceed.
and I'm checking for capillary refill. And if it is less than 3 seconds, it's normal.
Less than 3 seconds. Proceed.
I'm checking for peripheral pulses, posterior tibial, dorsalis pedis. If it is palpable, looking for radium volume.
Okay, so the peripheral pulses are feeble. Any other pulse that you would like to see? If posterior
And
tibial is feeble and dorsalis
I'm
pedis feeble.
And I will also be checking the femoral pulse and also be checking radial, and I'm checking any delays in that. And now I'll be palpating for any tenderness along the leg, calf muscles, and also, thighs. Is there any tenderness, any crepitations, any swelling?
And what else? Special test.
So now, Mr. John, I'll be raising your legs up, and I'm looking for any pallor. Um, Ideally, I'll be keeping it there for 30 seconds, but for the time constraint, I'm just looking for if any color changes, if the becomes paler.
Okay, so there is pallor positive on elevation and rubor on
Okay.
dependence. So no,
Okay.
any other test that you would like to do next after that?
Well, I would like to check the, I would like to do the cardiac examination, and also check for any bruise, carotid bruise, and also, a radial pulse, and also checking aortic bruise and renal bruise. And I'll be, completing my examination by checking the sensory sensation and also the reflexes.
And one more special test that you will order in this case. You won't do it, but you will
Okay, I'll
mention.
be checking the blood pressure in the arm and also in the ankle. So ankle brachial fluxes, if it is, and if it is index, and if it is less than 0.9, it is positive, and it shows that there is a peripheral arterial disease, there, and we will manage accordingly.
Okay, good. So, if a patient comes to you and the patient has pain in the calf muscle, so because we're doing the leg, so let's do it right there and then. So, what test, what will you do if you're suspecting DVT in the patient?
So I'll be measuring the both, calf muscle and checking for any measurement differences more than 3 centimeter. So any redness, swelling.
Thank
Okay,
you.
got it.
Okay. So, anyone else who would like to volunteer for any exam?
Yes, I can.
Okay, so Papa, you can do examination for Parkinson's disease.
Parkinson's disease. Okay. Okay, now, John, I want to do, I want to check your gait. Could you please stand for me and please walk for me? I am looking for shuffling gait.
The
And
patient is walking in blocks.
okay,
I have
and
shuffling gait.
can you please stand for me and close your eyes? I am looking for the Romberg test, and I'm checking for imbalance of the patient.
When you do the Romberg's test, how will you stand with the patient?
I will stand in the back of the patient to keep the patient and to protect the patient and ask the patient to close the eyes. And if the patient lose the control and balance, the Romberg test is positive.
Yeah, so don't forget the step to stand behind the patient and extend your arm as if you're trying to save them from falling. Okay? Because there is a mark for this point. Okay. Well, move forward now.
And
Next.
now I want to check. Can you please bring your hand forward? And I am looking for the tremor at the hands and looking for the resting tremors. And can you please write for me? I am looking for micrographia whenever the patient is writing. And uh, I am. Can you please flex your elbow? I want to check the cogwheel rigidity. I want to open up the elbow and looking for any cogwheel sensation whenever I want to open the flex elbow.
Okay.
And should I go for the cranial nerves? I'm not sure.
That's fine. No, cranial nerves, it's okay. You can omit. What will you ask in vitals in this patient in Parkinson's? What will
For
you ask?
vital sign, I'm checking for orthostatic hypotension.
Good. Okay. That's what I wanted to bring in.
And
Okay.
Dr. Sana, here, bradykinesia. So bradykinesia is very important part of Parkinson's. So can we start with, like, after inspection, bradykinesia? you know, that maybe move, do something, certain movement as fast and as big you can, like, you know, opening
Yes.
your maybe two fingers or, and
Yeah, so
after that.
you can check for cerebellar signs. You can go for this diodokinesia, finger to nose testing. So that will be slow. The patient will be very slow in those movements. So yes, you can start
Is
with
that
the
not for cerebellar, like, you know, cerebellar, the coordination? Because bradykinesia is the
yeah,
slowness of the movement. So
yes.
if we are doing this diadochokinesia, is it like fulfilling the checking the bradykinesia?
No, it is just for coordination, but you will see that the coordination is slow, but it is intact. So if it is intact, that means that, yeah, because the patient is still able to do that movement. So you are doing two things simultaneously, like you are
Okay.
checking
Ruling out and then, okay.
yeah, so you're seeing that the patient can still do that movement, but it is slow.
Okay.
So that is cerebellar signs are negative. It's out. It's not cerebellar sign,
Okay.
but it's slow. So the other things you can tell the patient to get up from the chair and see if it's taking them a lot of time. Plus
And
what?
then finger to nose test, will we be keeping our finger at one place? Because in cerebellar,
No,
they you know, change the position for
you
to
have to
check that,
change.
change the
You know,
position, right?
you will change the position. Yes, you will
Okay.
change the position.
Thanks.
Yeah, you're welcome. Okay, so after that we can do one more examination and then we'll close the session. It's 10:36, so it will be 1 hour after that. So anyone else who would like to volunteer? Anyone?
Me,
I can do.
Okay.
doctor.
Okay.
Okay, who was that?
Uh, me.
Okay, Dr. Hindia, it was you. Okay, so you can go for a stroke assessment of a stroke patient, examination of a stroke patient.
Okay, Mr. John, now I'd like to examine you. Is that okay?
Yes,
I'm
doctor,
just
that's
going
fine.
to clean this on general inspection. The patient is sitting at the edge of the bed. He seems comfortable and not in acute cardiorespiratory distress. There's no visible change in color or any swelling as well. Mr. John, can you please walk to the door and back for me? I'd like to check the gait to see if there's any antalgic gait and any limitation of movement as well. Also perform the Romberg's test. Mr. John, I'll make sure you don't fall. Do this for a few more seconds. And Mr. John, you can sit down. I'd like to check for the pronator drift. Can you for me? I'm just checking for the pronate if there's any drifting of the hands in this test. Thank you.
So how do
Mr.
you
John,
instruct the patient to do
hmm?
for checking when you're checking for pronated drift? What instructions will you give to the patient?
For him to close his eyes, to keep his palms up and close his eyes, and for a few seconds to see if there's any pronation of the hand
Okay,
for a few
good.
seconds.
Mm-hmm.
And now I'd like to check for cranial nerves. Have you noticed any change in your sense of smell, Mr. John?
Maybe not doctor. Yeah.
Okay, now I'd like to also do the cranial nerve 2 examination, check for visual fields. Can you close and also instructing the patient to close one of his eyes and checking for his fields. Now I'd like to also check for visual acuity by using the Snellen's chart, telling him to read the letters below and also the colors if he can identify those. I'd like to also do the fundoscopy to check for any papilledema. Now I'd like to check for cranial nerve 3, 4, and 6. Check his extraocular muscles. Do the H sign. Make sure for him to follow my fingers, and also use my torch light to check for his papillary reflex bilaterally if it's reactive to light or not. I'd like to also assess the cranial nerve 7. Can you please puff for me? Can you smile for me? Show me your teeth. Can you frown for me as well? Checking to see if there's any absent nasolabial fold, if there's any deviation of the facial muscles. I'd like to also quickly check the trigeminal nerves. Can you clench your jaw for me? I'm just checking if there's any, I'm looking at the jaw, the strength. And also, now I'd like to go to the gross motor motor examination. Can you move your hands for me? Okay. Can you can you resist me? I'm checking for the hands and the lower limb as well for the motor examination. And now I'd like to check the tone to see if it's hypotonic or if there's any rigidity of the tone of the upper and lower muscles. I'd like to also check for a reflex at this point of the triceps or biceps reflex at the upper limbs and lower limb ankle reflex. And now I'd like to also check for sensation, upper and lower limbs. I'd like to also check for clonus at the lower limb and also, yeah, I
Okay.
think
So,
I forgot
so
things.
So that was a very, Dr. Hindi, a very good and very thorough examination. But there is one thing that in stroke patients, we go for fast assessment first. So it's a quick stroke screen. We do that first, and then we go for the rest of the examination because the examiner wants to see that what is your approach towards a stroke patient. Because in stroke patient, we have to be very quick because we have to give them, TPA. So you will say that to quickly assess for stroke, I will perform the fast screening test. Okay, so for what is fast? Your face, then A is for arms and legs, motor function, and S is for speech. So you rule out these three things first, and the time, of course, T is for the time that when the symptom started. Because if it is less than 4 hours, 4.5 hours, then we can initially start the patient immediately on TPA. So that's why you will say that for face, you will check the face first. Can you smile for me? I'm checking for facial asymmetry or drooping. Then for the arms, motor function, you will check in arms and legs both, upper and lower both limbs. So please raise both arms and hold them straight out with your palms facing up for 10 seconds. So you are here checking for the pronator drift. And then now lift your leg up while lying down and hold it up for 5 seconds. So you are checking for leg weakness if the patient can hold the. So you have checked motor function, you have checked face. Now for speech, can you repeat the sentence after me? You can give any sentence. For example, today is Tuesday or today is a sunny day or whatever, and you are assessing for slurred speech. So when these three things are positive, you will say that the patient is having some neurological deficits. So I will immediately and these started like 2 hours back. So I'll immediately start the patient on TPA, and then I will proceed for the detailed neurological assessment, and then you go with the rest of the examination. Okay. Because in stroke patients we have to be very quick. So this is the whole point of doing examination, that you first go with fast assessment, and if once you know that it's a stroke, then from there you go with the neurological rest of the neurological examination. Yes, Dr. Fariba, your question.
Yeah, thank you so much, Dr. Sana, because that was a point, that because the time is the key and fast is the last thing is time. So we need to,
Yes.
and at the end we need to tell them that we, so at the end we will can we say that we will be urgently contacting the contacting the stroke team, or we will say that we will start the TPA.
So you will say that I will urgently contact stroke team and start the patient on TPA,
Okay.
because this happened 2 hours back and fast assessment is positive for this patient. After starting the patient on TPA, then you can go for I will now complete the rest of my examination by going for complete neurological examination. So later on, then you can do whatever you want. Yeah, but TPA
Okay.
is the key.
And just last question.
How about
Yes.
My side, that when you, if the patient is sitting, for example, or standing, for example, standing, and we can say there is a chair, we can just sit down, can we do that leg, that raise your leg for a few seconds instead of asking or lying down?
Patient should already be in the bed.
Okay, right.
Yeah. So a stroke patient would already
um,
be in the bed. Yeah.
and we can do the arm test even if he's lying down, can we?
Yeah. So for the like usually they are the patients in which you have to do some sort of an examination like cardiac examination, abdominal examination. They're usually there at 45 degrees already. The position is there.
Got it.
So if the patient is at 45 degrees and a stroke patient is there, so
Mm.
you can do the
You,
pronator drift.
yeah, 45, yeah.
You can do that.
Thank you.
You're welcome. Yes, Fariba, your question, please.
yes, Dr. Sana, how about the CT scan? Do we should we order CT scan or tell the examiner that we are going to send it to CT?
Yes, so CT would be a part of your management, and if it's physical history and examination. So first you do the history, then the examination. In examination in stroke patient, once you're done with fast, you will say that since the symptoms happened, these days 2 hours back, so I will arrange for an urgent CT, and after seeing if it's an ischemic stroke, I will go with the TPA. You
Yeah.
can say that, yes.
Because if it is a hemorrhagic stroke, we
Yes,
don't.
then we will not. Yes, we will not go for that. Yes.
Dr.
So
Sana,
CT,
thank you
yes,
very much for this session. I
yes,
have a question.
yes.
While examination, we should speak to patient, but I see that some of the candidate they are speaking both at a time. They are asking the patient to bend their arms, and side by side we should verbalize that I'm performing this test just like I'm going to perform Thompson test, Burger test. We have to verbalize the examiner as well same time.
So yes, we have to verbalize what we are saying. So what you like, for example, if you're doing the Berger test, you will say that now I'll be doing some special test. So can you? I'm performing Berger test. So can you elevate your leg? And I'm looking for Palaron elevation and Ruberon dependency. So the examiner will give you the findings. You don't have to talk to the examiner or look at the examiner. Throughout the examination, you have to look at the patient. For example, even if you're doing the abdominal examination, keep your hand on the abdomen, but look at the face of the patient. Okay, just don't look at the abdomen, look at the face of the patient, and then do the examination just to see that if patient is comfortable or not. Because if the patient gives the facial expression, you should be able to catch it that the patient is in pain. So keep looking at the face of the patient, don't look at just the abdomen. And examiner is just standing there, forget about him. Whatever findings are positive, he will give them to you.
No, I just want to clarify that this is the best idea that we should verbalize what are we doing.
Yes, yes, you have to verbalize that
We
as
are
much
not
as you.
we are not in the direct what you say in the communication, or we're not looking at the examiner, but we are verbalizing everything.
You're
That
verbalizing everything and you're looking at the patient.
okay, thank you.
Yeah. So, for example, if when you're checking for the abdominal examination, you will say, okay, John, can you please lie down? I will start by you will go to the foot end of the patient and you'll inspect. So you'll say that I'm standing here, looking at your abdomen, and I'm looking for any visible, scar marks or whatever you're looking for, abdominal distension, all those things. Then you come towards the side of the patient and you'll say that okay, I'll now start palpating your abdomen, and if you have pain anywhere you can let me know. So if the patient says I have pain, for example, if the patient is holding on to the right quadrant and saying that I have pain here, you'll say okay, I'll be coming to this area in the end, so I'll be starting from the left lower quadrant, moving all the way for superficial palpation. I'm looking for any tenderness. Okay, if there is something, examiner will give you. Then okay, now I'm going for deep palpation, I'm looking for any hepatosplenomegaly, and at the same time I'm looking for any rebound tenderness, rigidity, positive, negative, whatever. Okay, and at the same time, tell the patient, I'm going to, look, I'm looking at tenderness at the McBurney's point, or if you're looking for Murphy sign, do that right there, and then do that, and then complete your examination. So okay, talk to the patient, but verbalize everything.
Dr. Sana, I have one more question. So it's related to Afira's question. Like, she asked that, like, with the fast examination, and then we tell the examiner or patient that I will be referring you to, like, the stroke team. But usually the physical exam stations are like 8 minutes, and the task is always to do history and exam, and we will be having the 3 minutes for the post encounter. So
Yes.
can't we say like all this management stuff there, because then it will waste our time essentially. Like the task is not to like talk about the management, it's about just the examination.
So that is what you should do actually, that like you do not bring management or anything which is not a part of your task inside that designated time that you have. So do the physical, sorry, do the history. If your task is take a focus history and do examination, just stick to that. Then in the management you can bring all those points that I'll be sending it for a CT, I'll be doing this, I'll be doing this. But if the task says that outline on the door that examine the patient and outline your management plan, then in that case you can
Like,
bring those.
so we should like take cues from the doorway sign. If it specifically says just the examination, then do that. If it's saying
Yes.
like maybe outline few steps or talk to the patient, then we keep 1 minute for that, otherwise not.
Yeah. Otherwise not. Yes. Stay focused. Very carefully look at whatever your task is. If the task says take focus history next 11 minutes, just take the history. Don't go here and there. Don't start counseling. Don't start giving differentials. If their task is take history and do counseling, stick to that. History and physical, stick to that. So stick to your task, because they are also looking for this thing, that are you following the instructions or not.
Okay. Thank you,
So yeah,
Dr.
follow those things. So any last minute tips, Hindia? So I would just say that just feel that it's your clinic and you're working there, and exam, don't think that it's an exam, and just go with your natural reflexes. So that's just stay calm and don't panic. Yes, Dr. Afira?
Sana, for the last minute tips, like on that day, I know that staying calm, yeah, it's easier. I mean, we will try our best, and thank you so much for all your support. And this class, especially, it is really important. It helped us a lot. And just like I'm asking that on that day, is something you want to share, then should we take up, bottle of water or a granola bar or something, anything you want to tell us from your experience?
So, so I had a water bottle with me, but I had a small. They allowed one clear bottle of
Yeah.
water, so I had one small bottle with me in my pocket. But on each station, when I would sit, the water bottle would just fall out the floor. It was
Okay,
every
I got
station
it.
had, yeah. So and I would pretend that it's not my bottle, it's someone else's. I won't even look at the bottle. And when the buzzer would ring, I'll just quickly, look for the bottle and move. So I would suggest take a smaller water bottle. And to be honest, I don't. Your exam doesn't have a rest station, so I don't
Hmm.
think so. You will even have time to drink a sip of water. But it's a good idea to have it along with you. My exam had one rest station, so I had some chocolates and small water bottle with me for the sugar that you need on that day. So, but yeah, the thing is that just go with a positive mind and go with an open mind. Please ask open-ended questions. If the patient gives you a clue that I was not feeling the best today, so can you tell me more about it? Or I have not been eating well. Why you're not eating well? If the patient says I'm not sexually active, why you're not sexually active? Just don't think that okay, it's if they're not active, that's their choice. So ask open-ended question. If the patient says no, if you don't find any red flags, then skip that part and stick to your task. So you will be fine. Like most of you have been my students, so all of you will be fine. Just don't panic. That's my tip. Just stay calm as you can. So and the last day before the exam, please don't study. Take your mind off from everything. Give your mind a break, because it's a very long a 12 stations journey. So you have to, when I finished my last station in the exam, I didn't even realize that it was the last station. I completed that and I went to the first station again when the buzzer rang. So the volunteer was there. She came and she held me from the shoulders and she said, "My dear, it's over now." So,
Oh, this is
like, I
tip
was
of
really,
the day, by the way, Dr. Sana, that don't read it one day before, because I feel this is, it will
yeah.
it will serve us a lot.
No, no. Yeah,
So yeah.
don't change anything now. Like for example, if you're going for any classes or mock exams or anything, so don't change your style. It's your personal style. Go with your
Hmm.
personal style. Don't change your opening sentences at the last minute. That if someone tells you, "Oh, don't say this, don't say that," those are not the things that will give you negative marks. But if you forget your questions, that is something that will put you into trouble. So whatever style you have, go with your natural style. At the last minute, don't change anything, and don't study anything on Friday. Please, everyone, take a big break on Friday. Relax, eat well, catch a good night's sleep, because it's a long 12 stations drill. Yes, Tina, your question, please.
Yeah, Dr. Sana, I just want to reconfirm that when we are asking about the constitutional symptom, so like if patient is coming, he has chest pain, and then we are saying, do you feel palpitation or other symptoms? Is that possible? We can say that I can understand you have chest pain. Is there any other associated symptom you have with this chest pain? Because if we are saying palpitation or nausea, vomiting, maybe we miss 1 or 2 points, so it's better we will say this word that. Do you have any other associated symptom with this chest pain?
So yes, that would be your first opening sentence. That okay, I understand you're here with chest pain. Is there anything else that you're experiencing, or you want to share something. So if the patient says that it's the chest pain, so take one symptom, one presenting complaint at a time. Don't take chest pain and palpitations and everything at a time. So take chest pain first, explore it, PQRST, everything. After that, take the next thing, because if you take one thing and don't complete it, you will be lost in the station. So similarly for diarrhea, vomiting, if it's a case of hemolytic uremic syndrome or whatever, so diarrhea, vomiting, nausea, so do coca-B for each of them. And they know that if it's a long history, so you will have that time.
Okay, and I have just one more question, that when we are asking about the past medical history, we are saying high blood pressure, high cholesterol, and these are things. Instead of, we can say that any significant past medical history you have. So like, I just want like to save the time, just we can use
Yeah.
one sentence, and that is the best for us.
Yes, so when we were doing the classes, I always used to tell everyone that no, ask specifically, because I wanted you to know what specifically to ask. But now for the exam point of view, yes, you can say that open-ended question, that any significant medical history that I should be aware of. If the patient is nice enough, they will give you. If they don't want to give, or if they have the prompt that don't give history, if for example, if it's a specific history that they're looking for, so then they will say, okay, like what doctor? So you should know in that case what to ask for. For
Okay.
example, if it's a case of for example, fall or dizziness in a young patient, and you are saying, is there any specific family history I should be aware of? So if the patient says like what, so hypertension, diabetes might be a little bit relevant, but hypertension, rather than hypertension, a history of hokum would be more sensible in that case. That any
Okay.
history of young cardiac deaths,
Mm.
patients with cardiac deaths. So you should know what to. So open-ended question should be your first key, and then go for the next one.
Okay, thank you.
You're welcome, dear. Okay, anything else? Okay, so you're welcome, everyone, and thank you for your kind messages. So all the best, and all of you will be in my prayers, and I wish you all the best for the exam.
Thank you so
Thank you
much.
so
Thank you, and
much.
all the best, everyone.
Sorry, I have one question to chat for the trauma question. Yeah, so any for trauma cases? So for trauma cases, you mean if the patient is vitally unstable? In that case?
Yes, Dr. Sana.
Usually, vitals, they are not, if the patient is vitally unstable, it was usually the pattern of QE2 that you have to manage the patient side by side. But in case you get a similar situation that you get the vitals on the door and the patient is unstable, so you can always ask that, I can see that patient is vitally not stable, so I would like to stabilize the patient and then proceed with the history. So the examiner might tell you that, okay, you can stabilize and then you can manage. Okay, you can start the management. And once he says that, okay, the patient is stabilized now, you can proceed with history, then start the history. Otherwise, in usual cases, in NAC/OSCE, usually it is history and the vitals are given later on. So you can always ask. In all cases, for example, if you have a lab investigation to discuss, if you have any lab reports to discuss, lab interpretation is there, always ask that. Is it okay if I ask you some questions, or would you like me to go through this first? So similarly with the trauma, and all trauma patients remember ABCDE, primary and secondary survey. Don't forget that.
Okay, so I was a bit confused with the trauma case approach, Dr. Sana. So let's suppose it's like a trauma case. First, I take a little bit of a history, so I take the ample history, then I do a primary survey.
No, so in management part, or in if you have physical exam, then you will do the primary and secondary survey. You will say that I will start, since it's a case of trauma, so I will be starting with primary survey. My patient is talking, so airway is intact for breathing, whatever the findings are. For example, if it's a case of pneumothorax, hemothorax, so whatever management. So for breathing, I will do this. I will go for lung decompression and manage, tell your steps, and then your referrals, your for C, you will attach the cardiac monitor and take IV lines and everything, and then you can so for primary survey, so primary survey is your ABC. So you can just say that I will be maintaining ABC of the patient. So that would be airway breathing. Even in the pediatric cases, if you get a case of shortness of breath, so always say that I will admit this patient, start with ABC. of the by maintaining ABC of the patient. In a trauma case, you can say, okay, so my patient is talking, so airway is intact for breathing. If the patient is breathing normally, that's fine. If not, then take care of that part. And if breathing is also intact, then go with the circulation. That, for example, if it's a case of chest pain or whatever, so then go for circulation in that case. So ABC and then your management in trauma cases. Don't forget in all emergency presentations when the patient is presenting in ER. Okay. No, we don't
Dr.
have
Sana,
time to do that. Sorry, yes, Sophia.
so with regards to trauma cases, as you said, that we'll first take the history and then do primary survey in our examination. Can there be a scenario where the patient's like unconscious and then we have to do the primary survey first?
Very unlikely for Nakoski. Very unlikely. Yeah, unless it's your bad day. Otherwise, yeah, it's very unlikely for Nakoski because it's more of a pattern of QE to it when it used to be. So
Okay. And was there a case like a station in your when you were giving exam which took you out of like you weren't expecting it? Then if we have something like that, how do we like go about it?
yes, something that and that happened on two stations. That one station was there was another like presenting a plane was something else, and when I went in the room, so it was something else. After the first question, I realized, oh, it's another system. It's not the system that I was thinking of. So in that case, if you know how to proceed, well and good, just proceed normally. But if you cannot, and you take some time to organize your thought process, so just tell the patient that okay, thank you for sharing this information, I just need a minute to read the template, read the question again, because question is available inside the room as well. So you can just take the question and along with that, reorganize your thought process, or you can just say that I need a minute to reorganize my thought process, and then restart. So take a pause, don't panic. Whatever will come in the exam, it will be from the syllabus. It will like nothing, it would hardly be anything that you would not have heard of.
Okay,
So just
thank
take
you.
a minute and calm yourself down. Yeah, you're welcome. Okay, so RT, no, we don't have time to do primary and secondary. We just have to mention in trauma cases. You won't have time to do that. Okay, so anything else? All right, so I'll just be stopping the recording now. So all the best, everyone. We did not go through the abdominal and thyroid and respiratory examinations because they are very